Within the intracranial regulation concept, we have the exemplar of seizures, and that's what this little mini PowerPoint will discuss. We have two learning outcomes for this presentation. One is to identify the various types and causes of seizures, and the second one is to use the nursing process as a framework for care of the client with seizures. Seizures are abrupt, abnormal, excessive, and uncontrolled electrical discharge of neurons within the brain, and they can cause alterations in a client's level of consciousness and or changes in motor and sensory ability and or changes in behavior. Seizures are classified as partial or focal local seizures, and that those seizures originate in one hemisphere of the brain. Generalized seizures involve both hemispheres of the brain. You also have a category that's unknown, and that is because they have incomplete data to put it in either one of the other categories. And then a category called provoked, which is related to an acute condition that is a reversible condition, like a hypoglycemia seizure or a febrile seizure. Most seizures of all types of these that I just talked about, all the classifications, last somewhere between 30 seconds to 2 minutes. If a seizure lasts longer than 5 minutes, then medical attention needs to be sought. 5 minutes is a long time for somebody to have a seizure. Causes of seizure disorders include cerebrovascular disease. We just talked a good bit about strokes and how a client can have a stroke because of the lack of blood flow to the brain. So that same concept would also cause a stroke. So whether that's plaque building up in the artery and the artery is too narrow, or the clot is totally blocking the blood flow, or maybe hemorrhage, and any of those could cause a seizure. Hypoxemia, so lack of oxygen to the brain, can cause a seizure. Fever in children, also called febrile seizures, are if the fever gets too high, their body can respond with a seizure. I saw this a lot in pediatrics. Head injuries can cause seizures, as well as hypertension and central nervous system infections. Different metabolic and toxic conditions such as hypoglycemia, drug and alcohol withdrawal, brain tumors can cause seizures, and also allergies. So if a client is having a partial or focal seizure, you will see they will have clinical manifestations depending on where those neurons are discharging, right? So remember, seizures are abrupt, abnormal, excessive, uncontrolled discharge of the neurons. Well, depending on what part of the brain that seizure activity begins will depend on what you will see in your clients. So if your client has what's called a complex partial seizure, they will be having a seizure where they have lost consciousness, or they have a change in their consciousness or a change in their awareness. They may have behaviors that they're unaware of, such as picking at their clothing or smacking their lips. That is called an automatism. They will, again, like I said, lose consciousness. They could black out for several minutes. They often have amnesia that will happen just before the seizure and then just after. If the client has what's called simple partial seizures, those are seizures without any loss of awareness. You do not lose consciousness in a simple partial seizure. The client may have unusual sensations, unusual kind of like a sense of deja vu. They may have abnormal autonomic responses such as change in their heart rate, abnormal flushing. They may have one extremity that moves in an awkward position. They may complain of pain or an offensive smell. And that is what a simple partial seizure will look like. Clinical manifestations for generalized seizures. With the generalized seizures, they are often involve both hemispheres of the brain, causing both sides of the body to react. So there are 5 types of motor generalized seizures, and I want to mention, before I get into those, I want to mention the well, they're not called absent seizures anymore. They're non-motor generalized seizures. They used to be known as petit mal seizures. My nephew actually had these. They often occur in children, and they just sit and they stare into space. They might have some subtle body movements, might have some eye blinking or smacking of their lips, but they don't know what's going on, and for a very brief point in time, they kind of lose awareness. Oftentimes, they can occur in clusters. But these are considered the non-motor or absence seizures. But the generalized seizures that are in the motor category, there are 5 of them. The first one is a tonic seizure. So tonic seizures, only the tonic phase is experienced. Okay, so clients suddenly lose consciousness and they experience sudden increase in muscle tone, loss of consciousness, and then an autonomic manifestation, which what you see with that is apnea, where they're not breathing, arrhythmia, incontinence. They can have vomiting and salivate a lot, have a lot of secretions. Tonic seizures usually last less than 30 seconds, but in some sources, they can last for several minutes. The next one we're going to talk about is called an atonic seizure, and the atonic seizures are characterized by a few seconds in which muscle tone is lost. After that muscle tone is lost, the seizure is followed by a period of confusion. And because that muscle tone is lost, they often fall. So they could be standing up and then they have this atonic seizure, and because they don't have control of their muscles and it comes on all of a sudden, they can just collapse on the floor or fall. A clonic seizure is only the clonic phase. So this is usually lasts several minutes, and this type of seizures, the muscles contract and then they relax. So they have that jerky muscle movement, and it typically affects the neck, the face, and the arms. Myoclonic seizures consist of brief jerking or stiffening of the extremities. They can be either symmetrical or asymmetrical. And then the last one listed here is the tonic-clonic seizures. So a tonic-clonic seizure usually begins for a few seconds in that tonic episode. The tonic episode is where the muscles stiffen, and then they have loss of consciousness. And then that's followed by a 1 to 2 minute clonic episode of rhythmic jerking of the extremities, okay? So tonic is that stiffening of the muscles. Clonic is that rhythmic jerking. So with a tonic-clonic seizure, they have that stiffening of the muscles for a couple seconds, and then the rhythmic jerking for a couple minutes. You will see or can see that breathing may stop during that tonic phase and become irregular during the clonic phase. You may have your clients turn blue. They may have some cyanosis and some breathing irregularities. They will bite their cheek, bite their tongue, and that usually happens in the clonic phase. Incontinence can also accompany this type of seizure, the tonic-clonic seizure. And after the seizure is over in the post-ictal phase. The post-ictal phase is the name of the time period after the seizure. There will be a period of confusion and severe sleepiness following this seizure. They are just completely wiped out after these tonic-clonic seizures. So when someone is having a seizure, there are certain things that you can do to minimize their potential for injury. So the big goal for your care is to protect the patient from injury. If you're in the hospital and they have medication that is ordered, by all means, we can give that medication. But if the client is in the community or educating the client about seizure care of a patient during a seizure, the biggest thing is protecting them from injury. You want to get them to a private area if you can. So I showed you in the other slide that in the generalized seizures, they can have what's called an aura, or a little, like almost a premonition that they know that this seizure is going to come on. So they may have time to seek privacy. But if that happens, always make sure somebody is with them. We don't want them to seek privacy, go somewhere where there's no one to help them if they need help. But if they are standing, we want to ease them to the floor. If they're in the bed, let's keep them in the bed. Place the patient on the side with the head flexed forward. So this is very important because when you flex their head forward, it helps move the tongue forward. One of the major complications of a seizure is the tongue can fall back and in their mouth, and it can occlude their airway. So if you can, we want to place them on their side with their head flexed forward. If they're on the floor, you can put a pillow under their head to protect their head, because they will, or some kind of pad, because with the tonic-clonic seizure, their entire body will be doing jerking movements, so we don't want them to cause a head injury from this seizure. If you're in the hospital and you have suction available, go ahead and clear the secretions from the mouth, but only do that before they get to the point when their jaws start to clench shut. So in the seizures, if the patient's jaw is clenched shut, do not ever insert anything into the mouth, okay? So you never want to insert anything into the mouth. You never want to restrain them. If they have restrictive clothing, you want to loosen that clothing. Like if they have a necktie or a tight belt, you want to try to loosen that so that you can prevent injury. In the hospitals, I think the next slide might have a better picture, but there's something called seizure precautions. So seizure precautions with a client that is known to have seizures and is in the hospital will include having suction ready and available at the bedside, having oxygen ready and available at the bedside, padding the side rails. If a patient is in the bed and they start to have a seizure, you want to raise those side rails that are hopefully padded. Remove the pillow or any other blankets from the bed, because you don't want them to jerk. They'll be jerking and moving around, so you don't want anything to come in, impact their airway. And then you document, and that's in the next couple slides. For us visual learners, this is a great picture showing the plan of care for a client experiencing a seizure. As I spoke about in the previous slide, you want to have their side rails padded and up. You want to have oxygen and suction apparatus available. You want to put them in the lowest position. So lower the bed all the way down as low as it'll go. Make sure the side rails are up and padded. Provide them privacy, and then when they are in that post-seizure time, make sure that they are lying on their side in case they were to vomit. It looks to me here like there are no pillows or clothing or blankets that could potentially suffocate this person, and they have loosened the clothing as well. The time period after a seizure takes place is called the post-ictal phase. Your care for the client after the seizure has taken place in this post-ictal phase will be focused on keeping him or her safe and maintaining a patent airway. So you will want to place them on one side to prevent aspiration. You're going to want to facilitate any drainage of the oral secretions. So you may need to suction them. You will want to check their vital signs. You're going to want to perform neurological checks. You're going to want to assess them for injuries to see if they had injured themselves during the seizure. The client will need more than likely to be reoriented to the environment, because a lot of times in this stage they are very confused. They may become agitated. They may be extremely sleepy. It takes a lot out of them, these seizures. They may be apneic, which means they are not breathing, or they may need supplemental oxygen because they're having issues with gas exchange at this point. Your big interventions would be to keep their airway open and keep them safe. You may need to use gentle persuasion. You never want to restrain the client, but if they're extremely agitated, you're going to want to use some gentle words to get them to remain calm. So if the seizure is witnessed, we want to make sure that we document everything that we are witnessing, that we're observing. So what were the sequence events? When did it start? Did they scream out before it happened? Did they fall to the floor? What was going on prior to the seizure starting? Sometimes they might have what's called an aura, which is, it's described as a warning that sometimes people that have epilepsy or frequent seizures, and we'll talk about that in a minute, what they feel just prior to that seizure. So whether it's lights flashing or some kind of visual disturbance, some kind of warning that it's going to happen. So if that happened, we need, obviously you will need to wait for till they're aware enough to let you know that. You want to document what type of movements they're having. So again, remember, with the tonic-clonic seizures, you're going to have that that tonic period is the stiffening of the muscles, and the clonic period is when they, did I say that wrong? Yeah, clonic period is when they start jerking. They have rhythmic jerking of the extremities. So you're going to want to document how long they did either one of those activities. If you're able to look at their pupils while it's going on, what are their pupils? How are their pupils responding to light? If their eyes or head are turned to one side, if they involuntarily do that, not did you, or even if you did, we want to document that. The duration of each phase, like I just talked about, the tonic-clonic phase, usually the tonic phase only lasts a few seconds, and that clonic episode, that clonic phase, lasts longer. So you want to make sure you're documenting everything that you see at the end of the seizure. What type of movements were they doing? What type of cognitive status were they completely aware? Did they have that amnesia? Were they incontinent? That type of thing. So you want to make sure you document anything that you observe during the seizure. Epilepsy is a group of syndromes characterized by unprovoked reoccurring seizures. It affects about 3% of the people worldwide. Your book will say that most forms of epilepsy occur in children and older adults, and that there are more than 1 million American women that have epilepsy. Epilepsy is classified by specific patterns of clinical features. So it's classified by how old they were when they started having these seizures. Do they have a family history? What type of seizures are they? My sister-in-law actually was diagnosed with epilepsy when she was a child. She has since she's grown out of it, so she has resolved epilepsy. But primary epilepsy is considered idiopathic, and what that means is they don't know what's causing it. Secondary, the cause is known, and there's an underlying condition, whether that be a brain tumor or whatever it is that's causing it. But to be clear, epilepsy is the type of, or that's the disease. That's the disease that's associated with the spontaneous reoccurring seizures, and a seizure is the event. If you just have one, if your client just has one seizure, and they don't have these recurring spontaneous seizures, they don't meet the other criteria, then they don't have epilepsy. They're a person with seizures. So I've listed here different types of seizures that are not considered epilepsy. I think I mentioned a little bit ago about febrile seizures or febrile seizures, when a child has fever and it causes them to have a seizure. Toxic seizures and alcohol withdrawal seizures are seizures that are caused by coming off of alcohol, coming off of drugs. Metabolic seizures, when there's imbalance in electrolytes, there can be seizures. A convulsive syncope. Syncope is when you lose consciousness because of your blood pressure, and that's due to hypoxia or perfusion issues, and people can have seizures due to that event taking place. Let's say someone has a concussion, they can have an acute concussive convulsion or a seizure that's caused by that concussion, not considered epilepsy. And then seizures within the first few weeks after a brain trauma or infection or stroke are seizures that are caused by those things, and they also are not considered epilepsy. So clinical management or treatment of epilepsy, there are two categories, if you will: pharmacologic or medication therapy, and then surgical management. The goal is to achieve seizure control with as minimal side effects as we can do it. A lot of medications that are anti-epileptic have some serious side effects and some serious issues with toxicity. So we want to be really tight and monitoring, the physician does, with what they prescribe. The medications do not cure the seizures, they only control them. There are specific medications based on the type of seizure and how effective they are to that seizure. Again, I already said severe, a lot of side effects with the anti-epileptics, and the patient can be toxic on them. Up to 80% of the seizures so the medication can be effective for up to 80% of the people if they're prescribed and taken properly. And then usually the physicians, the healthcare providers, will start them on one medication, and if that's not working, they can take them off of that or add an additional one and adjust it as needed. With surgical management, obviously, if the seizures are caused by tumors or abscesses or things in the brain that we can surgically go in and excise, not we, the surgeons can go in and excise, that can hopefully, once they take that out, hopefully prevent seizures. And then there are some additional surgery therapies that are being tested where they can actually go in and identify what part of the brain is having that abnormal firing of the neurons, but we won't go into too much detail on the rest on those, because they're pretty much being tested all the time. But typically epilepsy is going to be handled or managed with medication. Status epilepticus is a repeated seizure activity within a 30-minute time frame, or a single prolonged seizure lasting more than 5 minutes. This is definitely a medical emergency. There are complications associated with this condition that are related to decreased oxygen levels, inability of the brain to return to normal functioning, and that continued assault on the neurons and the tissues that the neurons are, the tissue of the brain. It requires immediate treatment to prevent both permanent loss of brain function and death. Maintaining a patent airway and proper oxygenations are going to be your priorities. You will want to make sure that you establish IV access, you perform EKG monitoring to watch the heart and the rhythms, monitor pulse oximetry and ABG results. Oftentimes, these clients will be able to stop those seizures by administering medication via IV, so Valium, Ativan, Phosphentolin, those can all be given IV. I have given in the hospital Valium rectally, which has also been successful in stopping these status epilepticus. You're going to want to monitor those for imbalances of electrolytes and their glucose level, as well as their drug level the medications they might be taking for the anti-epileptics. And then continuously monitor their vital signs, their neurostatus, the respiratory status, and cardiac assessment. And then you will make sure that you'll follow up all the nursing management pieces that we talked about earlier with just one seizure also apply in keeping that patient safe and minimizing the injury to the patient. And that concludes the lecture on seizures. I hope you enjoyed it. The next lecture will be on headaches. Thanks a lot.